Good day, everybody. Welcome to Dr. Tom's Tips on Tuesdays at 10. My name is Rolando, and we're here with Dr. Tom Hirsch. So, last week, we introduced this whole five-part series. Today, we're going to see part two of five. Now, before we get into that, we got a couple questions about what Dr. Hirsch did last week, and I'm going to ask him, how are you, sir? How are things?
Good morning, Rolando. Hey, everybody. Thanks for tuning in to Tom's Tips Tuesday at 10. Everything's going great. Yeah. So, Rolando told me that last week when we were talking about things, there were a few questions that came up. And so, one of the questions that came up was, why do I do intraosseous anesthesia? Okay. It's plain and it's simple. Number one, the primary reason that I do intraosseous anesthesia is it is faster for me. If you do an IA block, an inferior alveolar block, it's predictable, but sometimes you have to wait. You can wait a minute, 2 minutes, 5 minutes, 10 minutes, 15 minutes. Sometimes you just plain old miss the thing. In a schedule of a day-to-day schedule, you just can't afford to be waiting around for so much time for somebody to get numb. The great thing about a intraosseous injection is the fact that it starts immediately. You do the injection and you immediately go to work. So if you just take that time of not waiting for a patient several times a day, you can save an hour or have an extra hour, hour and a half, even 2 hours to get another patient in and to be more productive in your day. So that's the primary reason for intraosseous anesthesia on the lower arch, especially the fact that when you're working on a patient, they're not walking out of the office numb. I don't like to be numb. You don't like to be numb. It's no fun. And if you have a patient that's running around numb for half a day, it's really no fun.
So, Dr. Tom, if I hear it correctly, it gets your patient numb almost immediately, and then the effects wear off so that they're not numb for the rest of the day. Is that correct?
No, not even almost immediately. It's immediately.
Oh, it is immediately. Oh,
right now. It's right now. By the time you remove that needle, you put a little astringent on the bleeding point, you start. There's just no waiting.
Huge time savings. That's
so
awesome.
So here, it's a time saver for you, and it's a time saver for the patient, and it's just a lack of frustration for the patient. Even if I've given an IA block, I'll still go in there if I feel that I need to and do intraosseous anesthesia. For you guys that are just coming out of school and just starting your practice, it's a huge practice builder. Huge. When somebody just walks around, little tingly lip instead of numb chin and jaw, huge.
Awesome. So now the second question that we got to ask is, you had mentioned that originally it might have been a crown, but you decided to go down the route of doing, I believe, an onlay and an inlay. Why?
Yeah. So tooth number 31 was going to be, it's fractured. It was going to be a crown. I like to be minimally conservative with my preparations. We were all taught that in dental school. Tooth structure is like God. You want to save as much tooth structure as you possibly can. So that's why I went with an onlay. That's reason number one. Number two, my margins are all super gingival. It's easier to capture an optical impression or a physical impression. It's quicker, it's easier, it's faster, it's better for the patient. If you have to go back later on and do a vitality test, you can actually get right to the tooth, the natural tooth structure, and do a vitality test. Why did I elect to go do 30 and 31? Was 30 okay for now? Yeah, 30 was okay for now. But besides you also have to think of your patient's time consideration. Do they want to come back 4 times for something that can be done in 1 or 2 times? No. They want to get in, they want to get it done. And yes, the cost to the patient may be greater on that one visit, but the cost overall for their time consideration and their time value of the cost value of their time, it's huge. They got to take half a day off of work to come and see you.
That is awesome.
So when I'm more productive, okay, look, bottom line, I'm more productive when I do it that way. If I can do 2 teeth instead of 1 or 3 teeth instead of 1, I will. And 2, it's just better for the patient. It's more convenient for them.
That's definitely it. So what we're doing now is we're getting into the prep. So I'm going to bring up the prep over here. Go ahead and take us through what's going on. And you've done the anesthesia and you're starting to prep.
We're
good?
done. We're starting to prep. We can see the fracture that's on the distal of 31. So I'm prepping. When I'm prepping, I'm using large diamonds. I love to use diamonds instead of carbides because carbides don't set up any fracture lines in the teeth. So that's why I'll use a large diamond. I get my diamonds from Microcopy. You can get them anywhere you want, but this is a large flat nose diamond. I guess he felt it, so I'm going back in there and I'm adding some more anesthesia. Sometimes if they feel things they weren't done right away, I'll go back in and I'll use some Septicane. You don't need very much, and once again, 4% Septicane is really good with 1 to 200,000 epinephrine. Just a little bit in there, and that's about all it takes. I use that gauze square because the astringent tastes really bad. It's the worst tasting stuff that we have in our practice. So that's why I use the astringent. And I put a cotton gauze square in there just so they don't taste it because it does taste really bad. So as you can see, I'm in here. I'm preparing the tooth. I use electric hand pieces. You can use electric hand pieces. You can use air-driven hand pieces. It doesn't matter. But the point being, in order to be efficient, you need a larger diamond to remove more tooth structure. So this is just me preparing this thing. No tricks. You've all learned what to do in school, so there's no tricks there.
Now, Dr. Hirsch, I noticed your hand placement on the handpiece. Why is it further back as opposed to all the way up by the head?
So you can see better. And I'm talking about the camera. I do a lot of the stuff that I'm doing right now. I'm doing for camera positioning. So that you can see better. If I had my hand up closer, my hand would be in the way. You wouldn't get a good shot. So that's why I do that. And sometimes what I'll end up doing is sometimes I'll end up using the actual mouthpiece to rest on, especially if I'm working on the left-hand side.
You'd mentioned before some clinicians had difficulty with that mouthpiece in there when they're doing the handpiece. And by pulling back the handpiece just a little bit, it gives you a little more room and you can actually see a little better. Is that right?
I see better, but really more so for the camera angle than anything else on this particular one. Also, if I'm in there, and as you're going to see in a little bit, I'm going to turn the handpiece to the lingual right there. Sometimes I bump into the mouthpiece. I can either push that mouthpiece back a little bit or just push up against the mouthpiece with my handpiece like I'm doing right now, and it just kind of moves out of the way as we're prepping that tooth.
And I noticed too that you're all the way in the back, so that gives you all the room. You can see everything, which is kind of cool. Now,
exactly. Hang on for a second. So here we go. So you can see I'm just prepping that. But one of the things that was important from last time, and I just want to reiterate this, is I'm using the medium DV mouthpiece because it gives me more room. It goes farther down into that lingual vestibule and just gives me more room to work. Some of you may not want to, worry about using two mouthpieces instead of one. As you saw me last time, I tried in the medium mouthpiece. You can just go right to the medium DV mouthpiece if you'd like. And here we go. You see me pushing on the mouthpiece right there with the head of the handpiece. I can bump.
And there's room back there?
Flexible. What's that?
There's room back there. It looks like.
There's room just because of the mouthpiece I'm using. And sometimes if there's not enough room, take the mouthpiece out for a second. It goes out in a second. You can take it out and work and put it right back in if you need to.
And that's what you do right there.
That's what I do sometimes. And I got to take it out to check occlusal reduction.
From a patient perspective, are there any considerations with regard, especially when you're all the way in the back? A lot of times people say they have difficulty gaining access to that second molar, second and third if they have it out there. Any thoughts or tips around that?
So one of the things that we'll do is I'll move the mouthpiece back on the opposite side. I'll push it back further. That gives me more working room if I need it. And you know what? Sometimes there's just not enough room, whether you have a mouthpiece in or whether you don't. The cool thing about this isolite thing is it protects the tongue. I mean, look at this. I don't have to worry about a tongue getting in my way. I have not cut a tongue in 20 years. And, not many of you can say that. As careful as we are, the tongue is always exploring. And that's, I'm not here to talk to you about mouthpieces. I mean, I am, but not really. The point is that it's just seeing what you can do there without the tongue getting in the way. Patients never know where to put their tongue. And, we're always scolding them. Oh, keep your tongue out of the way. Keep your tongue out of the way. Well, you know what? They don't know where to go to keep their tongue out of the way.
And then it looks like, too, you transition from that larger burr to a smaller one here in a second.
I can't tell. me see.
Here you go.
I might have as I'm going interproximal. Yeah. So now I'm just going in there with my finishing burr right now. It's a little 12 fluted burr. And so I'm just doing my my finish lines right there, my interproximal lines. As you can see, I've done that onlay, the MOD onlay on tooth number 31, and I've done the DO onlay on tooth number 30, going over that distal buccal cusp.
So when as you're treating this patient, any beyond that, any specific things that people need to be considerate of or mindful of? I noticed you started right away once you did your anesthesia. You added a little more, which is kind of cool.
Yeah.
And
sometimes you miss. Sometimes you don't have enough. Sometimes they're a little bit more trickier to get numb. So yeah.
Awesome. So next week, now that you've finished your prep, typically how long does it take you to do your preps, and what are some tips that you can share with our viewers regarding how to and what you've learned over the years with regard to prepping?
Yeah, with regard to prepping, it typically takes me 5 minutes to prep a tooth. There's no magic in it. We've all learned in school. Just get in there, picture in your own mind what you want the final result to look like, and go to the final result in your own mind. Just
right on.
Work. Go to work.
Perfect. So next week, what we're going to see you do is you're going to do a scan with your patient, and then also we're going to actually watch you in creating the actual restoration. This is a same-day restoration for both an onlay and inlay. So we're really excited about that. Dr. Hirsch, thank you so much for doing this. Really appreciate it.
Yeah.
We'll see episode 3 of 5 next week, and we'll keep carrying on. Folks, if you have questions about it like we had earlier, or if there are things that he's doing, Dr. Tom is doing, that we don't notice, please let us know, and we'll looking forward to seeing you next week.
Okay. See everybody.
Thank you.
Thanks, Rolando. Good to see you. Bye, everybody. Have a great day.
All right.